Modern cardiology treats coronary artery disease as an inevitable consequence of aging. The clinical standard of care relies on managing the downstream symptoms using statin therapy, bypass grafting, or PCI. PCI, or percutaneous coronary intervention, is a procedural intervention used to mechanically stent open clogged arteries. These tools effectively delay mortality, but they assume the underlying structural failure of the artery is permanent. An emerging consensus among lifestyle medicine researchers directly challenges this assumption. Coronary artery disease is a highly reversible pathology, provided the conditions driving the disease are removed. Reversal requires crossing a very specific biological threshold. The required intervention is an ultra-low-fat, oil-free, whole food plant-based nutritional protocol, where fat intake is strictly limited to approximately 10% of total daily calories. Treating the late-stage symptoms of the disease without crossing this upstream nutritional threshold guarantees that the cellular mechanics of plaque formation will continue unchecked. The clinical validation for this 10% threshold comes from the Ornish lifestyle heart trial. This prospective study was uniquely rigorous because it utilized quantitative coronary angiography to measure physical changes in the lesions. Quantitative coronary angiography is a medical imaging technique used to calculate the exact physical dimensions and narrowing of blood vessels. This dual-axis line chart tracks the trajectory of arterial stenosis over 5 years. The control group followed standard of care recommendations, consuming a 30% moderate SAT diet. Over the timeline, their average diameter stenosis worsened from 42.7% to 51.9%, pulling them into severe occlusion. The experimental group followed the 10% fat whole food plant-based protocol. Their physical stenosis measurably regressed to 37.0%. The data lines completely diverge, separating structural decay from structural healing. Dr. Caldwell Esselstyn's 12-year longitudinal study corroborated this divergence in a cohort of severe end-stage patients. By using entirely nutritional methods to maintain total cholesterol below 150 milligrams per deciliter and LDL below 80, 73% of adherent patients experienced measurable disease reversal. LDL, or low-density lipoprotein, is the primary molecular carrier of cholesterol in the bloodstream. Moderate dietary changes do not yield moderate regression. In patients with advanced disease, a moderate approach yields no regression at all. Atherosclerotic plaque initiates when a high concentration of circulating LDL creates a physical gradient, forcing the particles to cross the endothelial barrier and accumulate inside the arterial wall. Once retained and modified, the innate immune system recognizes the LDL as a danger signal. Monocytes are recruited to the site, differentiate into macrophages, and consume the trapped cholesterol until they swell into immobilized, lipid-laden foam cells. Plaque regression is dictated by physics. Circulating LDL must drop below 70 milligrams per deciliter. At this concentration, the gradient reverses. With the outward pressure removed, the trapped foam cells successfully execute reverse cholesterol transport, offloading their heavy lipid burden back out of the arterial wall and into the bloodstream for disposal. Without the aggressive lipid reduction achieved through an ultra-low-fat diet, the gradient never inverts. Retained cholesterol cannot be cleared. Dietary fats act as active immune triggers. High-fat meals elevate circulating LDL, and they actively initiate a systemic immune response known as metaflammation. Saturated fatty acids function as molecular danger signals. They bind directly to TLR4. TLR4 is a pattern recognition receptor on the cell surface, typically responsible for detecting lethal microbial toxins. This binding triggers an intracellular cascade. TLR4 promotes NF-kappa B signaling, which commands the cell to mass-produce inflammatory cytokines like IL-6 and TNF-alpha. NF-kappa B is a protein complex that controls the transcription of DNA, while IL-6 and TNF-alpha are signaling molecules that promote systemic tissue inflammation. These inflammatory cytokines migrate to the plaque and actively attack and weaken its fibrous cap. This chemical degradation drastically increases the lesion's vulnerability to sudden rupture and thrombosis. A high-fat diet actively dismantles the structural stability of the plaque from the inside out by weaponizing the innate immune system. The ultimate biological barrier of vascular health is the endothelial glycocalyx, a delicate, gel-like mechanotransducer layer of glycoproteins coating the inner lining of blood vessels. When this gel matrix is fully intact, it physically blocks circulating LDL and destructive immune cells from ever making contact with the vulnerable endothelial membrane. Consuming a high-fat meal induces immediate postprandial lipemia and massive oxidative stress. This metabolic surge acts as a direct chemical shear against the vessel wall. Under this metabolic stress, the protective glycocalyx is rapidly shed, disintegrating directly into the bloodstream and leaving the bare endothelial cells entirely exposed. Restoring the glycocalyx's physical integrity is a primary target of the ultra-low-fat protocol. Healing is impossible while the vessel's armor is constantly stripped away. This internal biochemical damage manifests as a tangible physical symptom. The acute sluggishness following a heavy meal is the result of measurable systemic endothelial dysfunction. A healthy endothelium produces nitric oxide. This critical signaling molecule commands the blood vessels to dilate and maintains an anti-atherogenic, non-stick surface. This line graph tracks flow-mediated dilation over an 8-hour timeline following a single high-fat meal. Flow-mediated dilation is an ultrasound measure of arterial health that calculates how effectively blood vessels expand in response to blood flow. Within 2 to 4 hours of ingestion, arterial dilation capacity plummets by 50%. The fat load generates reactive oxygen species that chemically intercept and neutralize the nitric oxide, converting it into peroxynitrite and instantly severing the vasodilatory signal. This defines the crossover limit. Eating a cheat meal resets a 6-hour biological clock of impaired arterial responsiveness, acute immune reactivation, and severe glycocalyx damage. Frequent dietary indiscretions trap the patient below this crossover limit. The vasculature is denied the stable, low-inflammation cooling period required to clear the lesion burden. The 10% threshold is supported by macroscopic population-level evidence. Entire human populations have historically lived completely free of coronary disease. Before Westernization, Okinawans experienced the lowest cardiovascular disease rates globally. Their traditional macronutrient profile consisted of exactly 6% total fat, derived primarily from the purple sweet potato. The China study data collected in the 1970s and 80s revealed a similar absolute limit. Rural counties consuming under 10% fat maintained a mean serum cholesterol of 127 milligrams per deciliter. Their coronary artery disease mortality rate was 1/17 that of the United States. These demographics lived their entire lives below the exact biochemical threshold required to prevent plaque initiation and immune activation. Standard moderate fat diets set at 25 to 30% may offer a baseline reduction in risk, but they wholly lack the biochemical intensity required to force regression in established arterial lesions. True arterial healing demands 3 absolute conditions: an inverted LDL concentration gradient, 0 TLR4 metaflammation, and a fully restored endothelial glycocalyx. An ultra-low-fat, whole-food, plant-based protocol is a strict, targeted intervention, engineered specifically to address the root pathophysiological drivers of this disease. By respecting the rigid biological thresholds of the vascular wall, patients and clinicians possess a highly credible non-surgical pathway to halt progression and achieve comprehensive cardiovascular reversal.